foundations of interventional cardiology, about basics uh, of coronary angiography and hardwares of coronary angioplasties. And I would first call upon Dr. Rajesh Vijayvergia to take a talk on the art of optimal angiogram. Dr. Rajesh is an acclaimed interventional cardiologist. His expertise, and he's known to all of us as a really national, leading figure in intracoronary imaging of OCT and IVUS. We all have learned a lot from him, but now he has to take a step backwards. And from intracoronary imaging, he has to go back to the luminogram of coronary angiogram. And I love to hear what Dr. Rajesh has to say about the art of coronary angiogram, more than the skill.
Hey, good afternoon, everyone. Thanks, Dr. Sethi, for the kind introduction. And this is the topic of my talk regarding basic of angiography views and PCI. As you all know, this is the cath lab scenario where we do in a central cath lab with the monitor, defibrillator is on the side. And for the angiography in routine, we do have the patient for the fasting 6 hours, though it's not a routine to have no fasting, but then sometime an emergency situation can arise and then you are supposed to have an intubation and anesthesia backup. So it's always better to have a fasting state for the patient when being taken on the table. Those who do have a renal failure, where there is a concern about, say, contrast-induced nephropathy, to be taken first few cases, and later on the rest of the cases can be taken. Yes, the angiography has to be done under local anesthesia, but one can need a general anesthesia in case the situation do deteriorate, and therefore what's a precaution to be taken for general anesthesia should be there for each and every patient. What's the site of access is there for the angiography that has to be saved, disinfected, and sterile atmosphere should be there. And this is about the catheterization trolley. You do have the 3-way syringes and various essential things which is available with the long line. And this is about the transradial access. Can you give the mic, please? Is it okay now? So this is about the transradial access, and another one is transfemoral. You have to see the puncture site in transfemoral, the femoral. Is it audible now? Okay. So it's a transfemoral access. Under the fluoroscopy, one has to see the femoral head, and thereafter one can go ahead. Few people do go ahead with the ultrasound to look for the femoral artery site, and it should be about the bifurcation and the head. So then, following the intervention, you can very well have a good compression without having pseudoaneurysm or hematoma formation. After the access, yes, you have to push the catheter through the seat. Most of the time, it's a 6F seat over the wire, connected with the three-way. This is the contrast. Sometimes you do have a line across for the contrast, and selective cannulation of both the left and right coronary artery has to be done to look for any blockade and then to go ahead for the intervention. So regarding the views, this is RAO and the LAO view which has to be taken, and then again this is right and left, and then caudal and the cranial. These are the various views which has to be taken during the angiography, and these are the two important plane one should understand about atrioventricular and interventricular plane. The first diagram is of atrioventricular. Sorry. So here you can see Can the marker is visible? Can you help me?
Go on to the next slide.
Marker, please. Okay, fine. So here you see, this is the right coronary artery. Basically, this is, one can say, RA view. This is the right coronary artery, which goes into atrioventricular groove, and same is true for the left circumflex. Both the vessel do go into the atrioventricular groove. And then this is basically the iliocranial, where this is the LAD, which goes into the interventricular septum. The posterior part of interventricular septum being supplied by the PD branch, which can be from right coronary artery in, let's say, 85% of the cases, and 15% of the cases it's from the left circumflex. And therefore, one to mention as the right dominant versus left dominant, depending on the origin of the PD. And then we do come across various branches. This is the epicaudal view. The first one, you can very well appreciate the good left main over here. The proximal and the distal part of LCX is well visualized. And this is the OM, or obtuse marginal first, obtuse marginal second, and this is small vessel is the left circumflex. So the distal LCX is the one which do go into the interventricular groove. And depending on the origin of the OM, one can very well divide. So LCX before the OM is the proximal LCX, distal to the OM is the distal LCX. In this particular view, you can very well appreciate the proximal LAD, and this is the epicranial view where the LAD proximal, or rather mid to distal LAD, is well appreciated. Whenever there is the left dominant circulation, you can very well appreciate the PD over here. And this is the epicranial view where you can separate the two. Here are the diagonal, the bigger diagonal D1 and D2, and these are the various septals arising from the LAD. How to divide the LAD? So S1, the prominent S1, this is over here. So before the S1, the LAD is the proximal, and the D2, this is the D2. So proximal S1 to D2, the distance between the two is the mid LAD, and after the D2 origin, it's the distal area. So this is the way one has to handle differentiation. And you can very well appreciate in this particular view, you can very well visualize the mid LAD and distal LAD. So during the intervention, this is the view to go ahead for the intervention of this particular segment. And this is the iliocranial view where you can very well separate the LAD with the diagonal. This can be, and this is also the view which has to be seen during the left main ostial stenting. Another one is commonly known as the spider view. This is the iliacaudal, where you can very well appreciate the proximal part of the LAD of the LCX and also the left main. There is some modification. This is the areocranial view where you can very well appreciate the proximal LAD along with the mid to distal LAD and also the left main ostium. So this is the one view where when the intervention or stenting has to be done, you can go ahead for the left main ostium stenting and also proximal to distal LAD stenting. Lateral view for the left coronary system, most of the time it is not been done, but then this is a very good view to differentiate a big diagonal from the LAD. So LAD do come anteriorly substernal, while diagonal is going to come over here. Sometimes with the CTO, chronic total occlusion intervention, when you are not sure about your wire is in the LAD or the diagonal, this is the view which can very well confirm. In case the wire do come like this is the LAD, otherwise it's going to be the diagonal. So these are the various views for the left system. Now comes to the right coronary. So around 85% of the cases, right coronary is dominant. And then initially you do have the two branches, conus branch and the SA nodal. In this particular case, SA nodal is quite small. This is the another one is the conus branch. And then the proximal, mid and distal RC have been differentiated by proximal RCA is the ostium to the RV branch to acute marginal is the mid RCA, and acute marginal to the distal till the bifurcation is the distal RCA. And then comes the PD and the PLV. The this is the lower one is the PD, which go into the interventricular septum posteriorly, and PLV is the one which goes into the AV groove. So this is the way how to differentiate the various branches, and this is the way how to have a nomenclature of the proximal, mid, and distal LED, PD, and PLV during the time of intervention. Most of the time, the LEO is the good view to go ahead for the intervention. RAO view is the one where you can very well appreciate the mid RCA. Sometimes the CTO intervention, when there is the RV branch, you are not sure whether you are in the RCA or it's the RV or the acute marginal branch. And this is the RAO view, which is going to be helpful to have an idea about that, okay, you are in the RCA proper instead of the side branch. This is the lateral view, which can very well differentiate the mid RCA from their branches, and this is another view which is of helpful during the PCA when there is a doubt about whether we are entering into the branch or the RCA proper. This is the AP cranial view where you can very well differentiate the PD and PLV very nicely for the right coronary artery whenever one is going to go ahead for the bifurcation is stenting at the distal part of the RCA and PDPLV. This is the view which is helpful to differentiate, to have a good delineation of these two branches and have a successful intervention. So all this is about the various views which are helpful during the angiography, something about the guide catheter which has to be used. You all know about what's the role of guide catheter. It's a vehicle for the contrast injection, measurement of the blood pressure across the aorta and the ostium of the right or the left coronary artery, conduit for the transfer of various wire and devices across, and support to give the advancement for the device exchange. A very important thing whenever you do go ahead for the catheterization, for the intervention, kindly take care of the blood pressure. Here is the ventriculization because you are not getting the proper transmission of catheter tip, and then possibly it's getting attached getting adjacent to the wall of the one of the coronary artery, and this is the damping which is one has to be very careful in case at this point or this point you have given the injection across the coronary. This is likely to have a dissection, ventricular tachycardia, and cardiac arrest. This type of pressure damping can be there in those with the small vessel and the large guide catheter, ostial spasm, selective engagement of the seconus branch, which around 20 to 25% of the cases, there can be two separate origin of the RCA proper and the conus branch, and then injection into the conus branch can lead to the damping and also the ventricular tachycardia. Sometimes the ostial stenosis of the RCA of the left may also cause the damping, and at that moment of time, one has to be careful in cannulation and to go ahead for the intervention. Catheter wise, you do have a 3-layer catheter for the guide catheter for the PCI. Outer one is polyurethane or polyethylene, and the middle one is the stainless steel, which is kink resistant, and the inner one is PTFE, which is smooth thrombus resistance catheter. Most of the time, the catheter has the length of 100 to 110 centimeter. They have a primary, secondary, and tertiary curve. Left Judkins do have a primary curve over here at the tip, and this is the secondary curve. And for the Judkins right, you do have an additional curve in the shaft. That's the tertiary one. Whether it's a 6F, 5F, or what sort of size is there, it's the outer diameter of the catheter. And the inner diameter is important during the intervention. And if you see for the 5 to 7F guide catheter, it's the Medtronic guide catheter, which do have a maximum lumen compared to other catheter. And it's going to be easy for the interventionist to go ahead for different bulkier device or two balloon when one is using the Medtronic compared to other guide catheter. There is a difference between the diagnostic versus guide. There are 2 layers for the diagnosis versus 3 for the guide catheter. Selection of the guide catheter during the PCI. Most of the time, it's the 6F which do help in crossing various devices, but whenever you do have a kissing balloon inflation or the rotabar, which is 1.75, there may be need for the 7F guide, and the 8F guide is very much restricted to those with a trifurcation region where the 3 balloon has to be used for the kissing inflation. The smaller size of guide catheter, yes, less of the bleeding, less of the contrast. Those with the contrast induced nephropathy, it's helpful, while the bigger size is helpful for the good support and exchange of the various bulkier device during the intervention. Then which guide to be used during the PCI depend on ascending aorta dimension. You do have the narrow, which is less than 3.5, ascending aorta 3.5 to 4 is the normal one, which we routinely come across, and the dilated ascending aorta is the more than 4 centimeter in the dimension. So this is the way to have the aortic dimension, and depending on this dimension, one has to choose the guide catheter, which cannot be the same one for each and every side of the aorta. And then there is a concern about the coronary ostium location and their takeoff. So coronary ostium location can be superior, anterior, or posterior, and similarly, the takeoff of the coronary can be different. This is about the left and right coronary artery, which do have a horizontal upper and lower takeoff for both the RCA and and the left coronary artery, which is well depicted in this particular picture. This particular case had the left coronary artery originating from the posterior side. Difficult to have nasal cannulation with a routine catheter, and it's ultimately the multi-purpose catheter which was used for the index case. Ultimately, with the CT scan, we could very well demonstrate the posterior sinus origin of this artery, and it's a EBU guide which was helpful for the PCI. And this particular case was published in the Indian Heart Journal. And regarding the backup support, it's very important to have a good backup support in those with the complex, tough lesion, those with the CTO, and it depends on the catheter size. 7F or 8F guide is going to give the good support, good backup support compared to 6F or the 5F size. And this particular angle, you can appreciate over a angle which is around 90 degree between this vertical line versus the aorta is the versus the catheter is the one. In case it's around 90, this is going to the good support compared to those with the more angle. And other thing is the contact area. A contact, you do have a support from the opposite wall of the aorta, from the sinuses and from the aortic arch. And then it's very important. This is very important thing that you have to have a coaxial alignment whenever you do cannulate the coronary. Otherwise, there is a risk to have a dissection and complication during the percutaneous intervention. Regarding the backup support, it can be passive. Passive means the guide catheter itself is going to give the support, whether it's a 7F or MPLARS or EBU guide, versus active support is the one where you do have a manipulation of the routine guide catheter to have a good support across. And this particular case where the distal RCA was diseased, and along with the bypass graft, you see the multipurpose catheter has come up to this point from the aorta to give the good support. So this is about the active support of the guide catheter, and we had a successful stenting of the distal RCA via the saphenous graft. And this is about the passive support. It's a AL1 guide. You see the mid RCA, which is markedly calcified or not able to push the balloon and various devices. So at this point, we have taken the guide liner at this point, and then successfully stenting could be done across this calcified right coronary artery with the passive support of the AL1 and with the help of the guide liner. Various type of guide catheters, some briefing about you have a GL varying from 3 to 5, and it all depend on the length between the primary curve and the secondary curve. So it's a 3, 4, and 5 centimeter is the length. And this type of say with the bigger size, in case the aorta is dilated, it's a bigger size of the Judkins left, which is helpful for the cannulation of the left coronary artery. Implants, again, 0.75 to 2 or 3 implants guide catheter. It's again the distance between the primary and the secondary curve or in centimeter, which is going to nomenclature. These various catheters, again, is with the aortic dilatation, one has to choose the bigger one. It's very important for fellows to learn about AL. AL to have a risk of coronary artery dissection. It has to be gently cannulated for the left coronary artery, and it's very important that during the removal, you have to push it so it get prolapse in the aortic sinus, rotate it to decannulate the left coronary, and then remove it. Or otherwise, when you are doing the PCI, you can put a balloon over here and over the balloon and the wire, you have to pull it out, and then otherwise there is a risk to have a dissection of the left main coronary artery. So you do an AR guide. It is again depending on the AR 1 to 3, depending on the aortic root size. Larger the size, you have to do AR 2 or AR 3. Most commonly, it's a AL1, which is used for the right coronary artery in the complex lesion. But then AR is another guide which can be of use. EBU guide catheter commonly used for the left current system. Depending on the curve of the secondary curve length, it can be defined as 2.5 to 4. And as per the aortic dilatation, the bigger size of EBU guide has to be used for the complex left coronary PCI. This is the Shepherd Cook, where the SCR guide from the Medtronic was used to have the PCI of the proximal RCA. And this is the high takeoff where the AL1 was used for the PCI. This particular case has now very high origin of the right coronary artery from the aortic ascending aorta, and it's around 3 centimeter above the sinotubular junction. Initially, there was some difficulty where the RCA is to localize the RCA. CT scan could confirm the origin from the ascending aorta, and then it's the AL1 guide which was used to have a successful OCT guided PCI. Got published in one of the European Heart Journal. And something about the dextrocardia. This is the case where you have to have an orientation. RA view look like the LAO and the vice versa. So this is the proximal RCA, which is 100% cut off with the acute MI, and successful PCI was done, published in one of the World Journal of Cardiology. And this is the another horizontal sweep reverse method. Each and every cath lab do have this modality. So you have to just flip the machine orientation from the outside, and then you have now rotation of this image. So epicranial and caudal will remain the same. RAO, LO will become the reverse. So if you see this particular image is basically the spider view. For the conventional normal angiogram, it's going to be the LAO caudal. But this is the RAO caudal in the dextrocardia patient. This is LAO cranial, but then in conventional normal angiogram, it's going to be the RAO cranial, and this is LAO for the normal RCA is turned out to be RAO. So you have to just reverse the image to have an idea about, and this particular study of around five patient experience we could publish in the Asia intervention. So take home message, choose the angiographic view for optimal profile of lesion prior to PCI and at the time of PCI as well. Mind that any extreme caudal or cranial view do have a more scattered radiation. So avoid this type of view more frequently and for prolonged duration during the PCI. And during the PCI, of course, an appropriate size and safe guide catheter is important. Once you choose a guide catheter, went ahead with the intervention, a complication in between like the dissection, you cannot change the guide catheter. So try to choose the appropriate guide catheter at the time when you are going to start the intervention, and then proceed accordingly. Thanks for the kind attention.
Thank you so much, Dr. Rajesh. I mean, if you may, just to, you know, We can take one or two questions from the audience if you have, for the sake of time. And before the students make up their mind, is there any specific indication where you will electively go for a femoral approach uh, in your practice nowadays?
It depend upon how you are trained. Most of my PCA initially was around 85% was transradial, which now is 95%. There is a concern about 6FC for the transradial and 7F with the transfemoral, but now with the 7F, 6F thermoseed, and you can very well place the 7F guide. One can go ahead with the transradial as well. Sometime when you feel like it's a CTO lesion and then you are supposed to have a good backup support, I would say transfemoral is going to have more backup support compared to transradial. So whenever you feel like that, okay, this is the case where you do need to have a good support, and there is possibility that you are not going to get the good support via the transradial, that's the time one can shift to the transfemoral asset. But then most of the time, it's a transradial, even with the 7F, one can go it for the PCI.
And for Lima interventions, what is your approach in terms of your access and your choice of guide?
For the Lima intervention, there is a concern about, say, length of the guide. So sometime you have to have a cutting of the guide catheter, and then to go ahead for this thing, either you can go from the left radial to a short distance and can very well go ahead for the intervention. For the Lima, it's one important point which has to be looked into is that you can very well place an additional wire across the subclavian artery, so you are not going to dissect the ostium of the Lima. Sometimes these are very tortuous and long, and then there is always a concern about whether your devices will be able to reach to the anastomotic side of the Lima to LAD or the distal LAD. At that moment, you have to modify the thing. I had tried few patients with the renal guide, which is of a smaller length. You go via the left radial, place it at the ostium of the Lima, and then proceed. And then because of the shorter length of the renal guide, you can go ahead with various devices extending up to the distal part of the LAD.
Sure. Any questions from the audience? So I suggest you all keep on, your mind should be clicking very fast as the speakers are speaking. Yes, please go ahead. Good. Take the mic. Take the mic. Take the mic, please.
When we fail in radial approach, sir, access, you directly go to femoral or you try ulnar, sir?
See, previously people used to do that particular test, Allen test. Allen test to look for patency and good flow across. But when you fail across the radial, it's preferable to go the alternative side, whether it's a left radial or femoral, instead of trying for the ulnar. In case there is any complication with the ulnar as well, you are going to have ischemia of the head, which is troublesome for both the patient and also for the physician.
Sir,
So what sir is saying is absolutely clear. If you have failed the radial, do not try an ulnar in the same hand, because then you have the chance of compromising the entire, palmar circulation. So either you go a left radial or you go femoral. That is your choice. But do not attempt the radial in the same arm.
Sir, another one question, sir. What we feel, many textbooks nowadays writing that machine injectable contrast. Machine will inject the contrast, you will program it. And we do generally manual contrast injection during angiography. So what is your view on use of machine for contrast injection rather than manually injecting?
I mean, automated injections are definitely things that are used in many of the Western worlds. I'm not sure whether Indian labs are doing it or not, but it's more about your lab setup and your technician setting it up in a right way. There's no right or wrong here. The machine-based injections.
Many observational studies show that automated settings require less contrast for equivalent results.
Yeah, so automatic pressure injectors for coronary arteries are are equally good and sometimes better in terms when you are doing OCT procedures and things like that. But for the lack of adequate technicians and the setting up of the whole equipment, many of the Indian labs are not doing it. That's what my assessment is.
Thank you, sir.
I would also like to add over here with the machine injection, you have fixed the amount of dye. With the experience, you have an idea about when to give the extra amount of dye during the diagnostic angiogram or during the PCA and when to give the lower amount. And this can be manually modified depending on the visualization. And therefore, the manual is going to be better. Sometimes you have the damping, and in case you have given the good amount of contrast across, there is going to be a dissection. So this is the way, most of the time, what I personally feel, you go with a small amount, less of force. Initially, look, everything is okay. And in case the thing is not getting visualized, you can give more force and more amount of contrast, both during the diagnostic and also during the intervention.
Yeah.